All right, today we are diving deep into a diagnosis that you absolutely have to have on your radar, infective endocarditis. This isn't just any old infection. It's a full-on assault on the heart itself, and honestly, just having that high index of suspicion can be the first, most crucial step to saving a patient's life. So, let's get right into it.
And when I say life-threatening, I am not kidding. 40%. Just let that sink in. That's the one-year mortality rate. It's a really sobering number, and it just drives home why catching this thing early is so critical.
So what exactly is infective endocarditis, or IE as we'll call it? Well, at its core, it's an infection of the endocardium. That's the heart's innermost lining. But it's way more insidious than that. It loves to attack the heart valves and can even set up shop on artificial hardware like prosthetic valves or pacemakers. It is quite literally an infection inside the engine of the body. To catch a disease like this, you have to know who's at risk and what signs to look for. So let's start there, with the first set of clues, the risk factors and the clinical presentation.
Your suspicion should really start building with the patient's history. Think of this as a sort of mental checklist. Does your patient have any prosthetic material, a valve, a device? That's a prime target for bacteria. Is there a super highway for bacteria to get into the bloodstream, like with injection drug use or an indwelling catheter? And this is a big one. Has this ever happened before? A past episode of IE puts a patient at a much higher risk for it to happen again.
Now, the presentation of IE can be frustratingly vague. I get it, but this classic triad should make your clinical senses tingle. A patient with a persistent fever you can't explain, a new heart murmur they didn't have before, and signs that little infectious clots are traveling through the body, like a sudden stroke. That patient has to get a workup for endocarditis, period.
And then you have these classic, almost textbook physical exam findings. They're caused by these tiny septic emboli or by immune complexes getting deposited. A great little trick to remember them. Osler nodes are ouch. They're painful little nodules on the fingers and toes. Janeway lesions, on the other hand, are painless spots on the palms and soles. And yeah, you'll need a fundoscope to spot Roth spots in the retina, but all of these are absolutely vital clues.
Okay, so you have your suspicion. It's strong. Now, how do you actually confirm it? Let's talk about moving from a clinical hunch to a definitive diagnosis.
This right here is the gold standard for clinically diagnosing IE, the modified Duke criteria. They basically take all our findings and organize them into this structured, evidence-based framework. You've really got to know these inside and out to diagnose IE confidently.
So the criteria are split into two groups, major and minor. The two major criteria are the real heavy hitters. First up, positive blood cultures with a typical organism that causes endocarditis. And second, imaging evidence, usually from an echo, that shows something's going on, like a vegetation on a valve, an abscess, or a new leaky valve. The minor criteria are all the things we've been talking about, having a predisposing condition, a fever, and those vascular and immunologic signs.
So, how do you put it all together to make the call? Well, it comes down to some pretty simple combinations. You can diagnose definite IE if you have two major criteria, or you can have one major plus 3 minor criteria, or even if you have no major criteria, 5 minor criteria will get you there. It's a really elegant formula that combines microbiology, imaging, and your clinical exam.
Speaking of imaging, choosing the right kind of echocardiogram is key. A transthoracic echo, or TTE, is your first stop. It's not invasive. It's a great place to start. But, and this is a big but, if that TTE comes back negative and you are still highly suspicious, or if you're dealing with a prosthetic valve or worried about a complication like an abscess, the transesophageal echo, the TEE, is way more sensitive. It gives you a much clearer picture.
Okay, you've confirmed the diagnosis. Now comes the response. You've got to act, and you have to act fast. So let's get into the management plan. The cornerstone of treatment is antibiotics, no surprise there. But the key is timing. You want to start them promptly, but only after you've drawn your blood cultures. The usual move is to start with broad coverage for the usual suspects, staph, strep, enterococcus. And then you can narrow down your therapy once you get the culture results back. And seriously, this is one of those cases where the infectious disease team is going to be your best friend.
But here's the thing. Antibiotics aren't always enough. Sometimes the infection causes so much structural damage to the heart that medication alone just can't fix it. And that brings us to a really critical question. When do you need to pick up the phone and call the surgeons?
So, what are the big triggers for an urgent call to surgery? Well, if that infected valve is failing and it's pushing the patient into heart failure, that's an emergency.
Other huge red flags are particularly nasty bugs like Staph aureus or fungi, or serious complications like an abscess developing. Also, if the infection is just raging on after a week of antibiotics, that's another big one. In these cases, you have to get in there and get the source of the infection out.
All right, let's talk about the final piece of the puzzle, prevention. How can we protect our most vulnerable patients from getting IE in the first place? Now, this is one of those areas where the guidelines have really changed over the years. We used to give antibiotic prophylaxis to a pretty wide range of patients. Not anymore. The approach now is way more targeted, reserved only for the absolute highest risk people who are undergoing very specific procedures.
So who are these highest risk patients? We're talking about a very, very select group. People with prosthetic valves or other artificial material in their heart, anyone with a prior history of IE, certain cardiac transplant recipients, and patients with specific kinds of congenital heart disease. That's pretty much it.
And it's not for just any procedure either. It's almost exclusively for dental work. Specifically, dental work that involves messing with the gums or could cause bleeding. Basically, anything that might give oral bacteria a free ride into the bloodstream of one of these very vulnerable patients. So it all comes down to the right patient plus the right procedure.
So to wrap this all up, we've walked through the risks, the diagnosis, the treatment, and even prevention. So I'll just leave you with this question to think about. The next time that patient comes in with a fever and a new murmur, what are your first 3 steps going to be? Think history, think cultures, think imaging. Being systematic can truly make all the difference.